In this video lecture, I'm going to talk about systemic lupus erythematosus or SLE. And as you may know that SLE is an autoimmune disease characterized by the formation of immune complexes which trigger inflammation and lead to tissue damage. Immune complex, it is formed of antibodies together with the antigen. So formation of immune complex activate the complement or the classical pathway of the complement, and this activation starts by activating complement component number 1. And as can be seen here, this is C1q of the complement component number 1. It binds to the immune complex, and this will initiate a cascade of activation and lead to formation of membrane attack complex and aflatoxins. Aflatoxins, these are complement component number 3, the short fragment, and the short fragment of the complement component number 4, and the short fragment of the complement component number 5. And actually this will lead to inflammation. So SLE is a multi-system disease and can affect many organs in the body, many parts of the body. And for example, as can be seen here, it has effects in various or in different parts of the body. This is, for example, the glomerulus or the glomeruli. So the position of immune complexes will lead to what is so-called lupus nephritis, and as you know that this deposition trigger formation of some cytokines, for example tumor necrosis factor alpha, interleukin number 1, and other interleukin number 17, and interferon gamma. These are pro-inflammatory cytokines and lead to inflammation or the nephritis. Similarly, if these complexes, these immune complexes, of course in the case of SLE, the immune complexes are circulating complexes. So when they reside, they activate the classical pathway of the complement. For example, here, if they resided here in the blood vessel, wall of the blood vessel, so they will bind to the endothelial cells of the blood vessels, and maybe these antibodies are anti-endothelial antibodies, and when they bind to the endothelial cell, this will initiate an inflammation in the blood vessels through some pro-inflammatory cytokines, and may lead to vasculitis. A patient with vasculitis may present you with pyrexia of unknown origin or excessive sweating, or may present with loss of weight, a picture that is very similar to a picture of patients with Mycobacterium tuberculosis. So, and also patient of SLE may present also with anemia, and this regarding the blood vessel when the immune complexes, as I mentioned, it is an immune complexes disorder. When these they reside here, they will lead to vasculitis. And in the lung, so immune complexes, when they reach the lungs, they will lead to pleurisy or inflammation of the pleural cavity. However, in the central nervous system, these immune complexes, when they reside here, the patient may present you with very severe depression or with abnormal headache, or a patient may suffer from change in the mood. This is the neurological manifestation of the SLE. In the tongue, so the patient in the mouth, the patient may present you with ulcers, oral ulcers, and usually these ulcers are painless ulcer. They are not painful ulcer. Regarding the joints, also it can affect the joint, but however, as can be seen here, the cartilage is intact, the bone is intact, the synovial membrane is intact. In contrast to rheumatoid arthritis, in case of rheumatoid arthritis, the bone and the cartilage get distracted with hyperplasia of the synovial membrane. But however, here the patient will present you with swelling of the joint with intact joint parts. And also patients with SLE may or cannot resist or cannot understand the ultraviolet radiation. They cannot withstand ultraviolet radiation. So this is known as photosensitivity due to SLE. So in the heart, as I mentioned, the SLE may predispose to pericarditis, myocarditis, or endocarditis due to deposition of these immune complexes. So now I'm going to talk about the predisposing factors or the exact causes. Actually, the exact causes for SLE are unknown largely, but however, we believe it could be linked to environmental or genetic or hormonal factors and defective immune system regulatory mechanisms. And in order to get any autoimmune disorder, one needs two factors. Actually, it is not single factor. It is constellation of factors. One needs two factors, as I mentioned. One factor is a genetic factor that predispose to the disease, but the other factor should be environmental, and the most important environmental factor is infection. And it could be smoking, could be silica dust, could be ultraviolet radiation, could be stress, and could be inhalation of heavy metals like airborne dust containing lead. So also genetic factors may play a role in immunopathogenesis of SLE. Recently, more evidence for the role of genetics in pathogenesis of SLE. For example, the occurrence of SLE in identical twins and the increase in frequency of SLE in first degree relatives, and the increased risk of developing the disease in siblings of SLE patients. And this actually reflects the polygenetic inheritance of the disease. And also an association of SLE with HLA has been shown, and it has been shown, the association has been shown between SLE and HLA, DR2 and DR3, which are common. These two, HLA, DR2 and DR3, with association between DR2, HLA, DR2 and HLA, DR3 with SLE is a common finding in patients of different ethnicity. So the presence of HLA class have been associated with the presence of certain autoantibodies, such as anti-small nuclear ribonuclear protein known as anti-SM, and anti-Rho and anti-DNA antibodies. So also the genes that encode HLA class 3, because we have HLA class 1, class 2, class 3, and the class 3 genes that encoding complement component number 4 and complement component number 3 confer risk for SLE. So inherited deficiency of C1q, this deficiency of this will lead to accumulation of these immune complexes and predispose to SLE. So deficiency or deficiency of C complement component number 2 increase susceptibility to the disease or to get the disease. And also hormones. Now we have some evidences that hormones may play a role in the pathogenesis of the SLE. For example, estrogen in females, estrogen in high dose facilitate humoral responses, and also it leads to increased B cell proliferation and may inhibit T cell responses, and thus estrogen aggravate SLE by enhancing B cell to produce autoantibodies. Similarly, prolactin, it has the same effect. And also defective immune regulatory mechanisms may predispose to SLE, and immune complexes, as you know, that as I mentioned, that immune complexes, they play a very central role in the pathogenesis of the SLE, as they binding of these immune complexes to complement component will go in a cascade that end in inflammation, or maybe chronic inflammation with subsequent tissue damage. So the defective immune regulatory mechanisms predispose to SLE, and the loss of immune tolerance. Actually, as you know that, or as you may know that, B lymphocyte and T lymphocytes, they originate from bone marrow, and B lymphocyte mature in the bone marrow, and during antigen independent maturation, that means B cells do not encounter any antigen in the bone marrow. Okay, so the immunocompetent B cell expressing membrane IgM and IgD are generated in the bone marrow, and only 10% of potential B cells reach maturity and exit the bone marrow. However, these we call them naive now B cells, and they patrol the body. And these naive B cells in the periphery die in few days unless they encountered antigen and activated T cell. So it is very important for B cell to encounter an antigen. And actually B cell here, this is the stromal cell of the bone marrow. So here through their membrane bound auto antibodies, they interact with cells in the milieu of the bone marrow. If they showed autoreactivity, they will be killed by apoptosis, and actually this is known as negative selection. And only well-educated B cells are allowed to go outside from the bone marrow to patrol the body, and actually during their circulation they enter secondary lymphoid organs. So they originate and mature in the primary lymphoid organ, which is the bone marrow, but however as the periphery they enter secondary lymphoid organ. And as you know that this is the lymph node, and also spleen is a secondary lymphoid. Lymph node and spleen, these are secondary, and as can be seen here, there is a lymph node and these afferent lymphatics, afferent lymphatics. As a periphery here, as the outermost of the cortex, we find B cell area, and then here there is T cell area, and they usually encounter an antigen here because antigens are bacteria or whatever, any antigens are trapped to the either lymph node if they are tissue borne, or to the spleen if they are blood borne. So here, when they encounter the antigen or the non-self or bacteria, whatever, they interact with the T cells, as can be seen here, and this results in formation of antibodies here. And these antibodies, if they did not encounter any antigen, they will die in very few days. So the loss of immune tolerance, this we call it immune tolerance. So B cell get education in the bone marrow in order not to attack body tissue. Okay, this we call it immune tolerance, and it is achieved by negative selection. Only educated B cells exit bone marrow and patrol the body. So the loss of immune tolerance, increased antigenic load, and excess T cell help, and it will result in defective B cells, and it will result also of shifting of T helper 1 to T helper 2, and this is actually very dangerous, as SLE is a T helper disease, or it is an antibody mediated disorder. So this will lead to actually loss of tolerance to B cell hyperactivity, and also in turn will lead to production of pathogenic antibodies. So, and now I will just also show you the immune, as I mentioned, immune dysregulation by loss of tolerance of B lymphocyte to B lymphocyte. This we explain now. Now I am going to explain the T cell tolerance. Tolerance means unresponsiveness to self tissues, to self antigens, to self organs. So T cells originate from bone marrow. However, when they originate from bone marrow, they are CD3 positive and CD8 negative. This is precursor of T cytotoxic, and CD4 negative, and this is a precursor of T helper cell. And the TCR, it is only beta and pre-alpha, premature. So when they enter the thymus gland, why T lymphocytes migrate from bone marrow to thymus gland? They migrate from bone marrow to thymus gland for maturation, for development of a repertoire. Development of a repertoire means that they express unique receptors for different antigens or pathogens in the environment even before they encounter that environment. Okay? Third, they get an education. How do they get education? Thymus gland, it looks like a school. So T lymphocytes, they come here. T lymphocytes, they come to thymus to get education. As the cortex, this is cut section. Okay, these are trabeculae. This is the capsule of the thymus gland. So immature T cells, they enter through high endothelial venules as immature and interact with the thymic epithelial cells. These thymic epithelial cells express major histocompatibility class 1, major histocompatibility class 2. So if these immature cells reacted with major histoclass 2, they will get differentiated into CD4. If they interacted with major histocompatibility class 1, they will get differentiated into T cytotoxic or CD4. And this is here, at this stage, they should recognize the major histocompatibility class 1 and 2 as self. And this is known as positive selection and ensures major histocompatibility restriction. So they should in the future time interfere with non-self or with pathogen in association with major histocompatibility. However, now this is the first lesson. They got it, and that failed to get this lesson, or that thymocytes failed to recognize this major histocompatibility molecules, they will be killed by apoptosis. And so here, but however, the positively selected, this we call it positive, they go deep, okay, and then they interact with macrophage and dendritic cell, and now they can see the body antigens. So these cells here in the thymus gland, dendritic cells and macrophage, they present body antigens, antigens of the heart, antigen of the muscle, antigen of bone, any antigen in your body except two antigens. They don't present it. Antigen is sperms and cornea. So the immune system should not see sperms, should not see the cornea. But however, these cells now, they can see antigens from all tissue of the body. And here, if they recognize the self-antigen as self, and if they recognize it, the self-antigen in association also with major histocompatibility, self-major histocompatibility, they will be saved. And but if they fail to recognize the self-antigens, they will be killed by apoptosis, and this is known as negative selective selection. Negative selection for insurers of self tolerance. So only 5% of T lymphocytes exit the thymus gland, and around 95% of thymocytes arrive to thymus will be killed by apoptosis. So, if, however, in some instances, some autoreactive T cells may escape, and some autoreactive T cells they express some cluster of differentiation. It is known as cluster of differentiation number 25, and they become a regulatory T cells. So negative and positive selection ensures self-tolerance, tolerance to self-antigens encountered in the thymus is thereby achieved by elimination or eliminating T cells that are reactive to self-antigen. So, positive and negative selection of thymocytes result in mature T cells, as can be seen here, are both self-MHC restricted and self-tolerant. And as you know that SLE is hypersensitive reaction type 3, because immune complexes in case of systemic lupus erythematosus are circulating immune complexes, and they are not membrane bound immune complexes. Thank you very much, Professor Ahmed Bolad.